Assalamu alaikum. Good afternoon, ladies and gentlemen. I'd like to thank Dr. Faisal for his invite, and I'd like to thank you all for accepting me to do this presentation today. So, mitral valve intervention is something new over the last 1 or 2 decades. We're still learning and we're still seeing a lot of things. Of course, you can see the mitral valve itself is an apparatus, and if you think that the problem is in the leaflets, then it is a little bit more and beyond this. We're talking about PAPs, we're talking about tendons, we're talking about muscle. So anything affects the apparatus of the mitral valve, it will cause a significant disease in the mitral valve. Probably this is the surgical view, and the surgeons are well aware about this. The anterior and posterior leaflets, scallops, anterior, A1, A2, and A3, and the same thing to the posterior leaflets. I'm just going to give you a little bit of orientation in transthoracic echo. Most of you are aware about this, but to go more in scallops, you can see in a left the mitral valve anterior and posterior, because this is the parasternal long axis view. You can go in a 4-chamber view. You're still beside the aortic valve and opening the aortic valve, so mainly you're seeing the anterior leaflet, and if you go a little bit more into a 2-chamber view, you're opening the posterior leaflet mainly. What pops in the middle, always, if you recognize here, what pops in the middle is A2, because the mitral valve is a sail-like. So whatever view you're cutting, most likely you're getting the middle, the A2 scallop. If you go a little bit more into a mitral valve scallops in transesophageal, you can have more details about this. And you can see the scallops more in details. If you go in a 4-chamber view and a 3-chamber view, this is exactly the mirror image. So you can see A2 and P2 scallop in the 4-chamber view, and the mirror of that is going to be in a 3-chamber or LAO. You can see anterior and posterior, mainly A2 and P2. And that also depends on the height of the transesophageal, whether you go higher or down. But this is mainly if you're in the mid of the transesophageal. So if you go a little bit shallow angles, you're opening mainly anterior leaflets. And if you go a little bit higher angles, you're going to open the posterior leaflets, because you're cutting through the mitral valve geometry. So the mitral valve in the short axis view, whether in transthoracic and transesophageal, it gives you a better idea about where exactly the jet is coming from. And you can confirm this with the transesophageal echo with the 3D and color. If you use also the QLab, that can give you more details about the mitral valve, the anterior leaflet, the posterior leaflet, and there are a few measurements you'd need to do. Probably the next speaker is going to go more when you're doing a mitral clip. So understanding the anatomy or the disease, why the valve is leaking, whether it's a primary or secondary disease. This is Carpenter classification. So if it's a secondary, sometimes you cannot do a mitral clip in patients with the restricted leaflets, with a high gradient, especially if it's a 3A in a patient with rheumatic heart disease. You might be doing it in a patient with a type 2, where there's a prolapse, or you can do it in a secondary MR. We can see that the ventricle is dilated. So degenerative and functional MR, they do not leak the same. In a degenerative valve, the main problem is in the leaflets, but in a patient with a dilated ventricle and dilated annulus, the problem is the apparatus at all, and it's usually elliptical shape as compared to a circular shape in a degenerative valve disease. So the severity of MR has to be 3 and above, and based on that you can decide your mitral clip or mitral intervention. If it is less than that, then most likely the MR is not related to, the symptoms are not related to the MR. So of course you can see here this significant MR. You can see you can calculate it by looking at the vena contracta flow conversion. You can assess how much is the area. It's mainly related to echo group. I'm sure that most of you are interventionists or surgeons, So probably this is meant for echo group to calculate how much is the BISA, and of course you calculate the effective orifice area, calculate the VTI. VTI is actually a distance where you do it with a Doppler, and you multiply area by distance, you get the volume. That's the math. And based on that, you can assess how much is the regurgitation volume and decide how much is the significance of MR. Another way of quantifying that by using the continuity equation, by taking Doppler in the LVOT and a Doppler at the mitral valve, and then see how much is that. So if you get 4 criteria based, this is the latest guidelines from ACC. If you get 4 criteria out of 6, you're talking about a significant MR. If you don't get 4 criteria, probably you'd need to go more and assess the regurgitation volume. If it's exceeding 45 or 60, then it falls into moderate to severe or severe range. Just when you select patients, you would like to make sure that the MR is, as we mentioned, is more than 3. Patient is really symptomatic, and you would like to also include patients who are high risk patients, like high STS score. It is exceeding 6 or 8. Patient has significant comorbid diseases like liver disease and others that cannot go for conventional surgery. Then you'd like to send them for percutaneous mitral valve solutions. This is just also for a secondary MR. You would like to have patients between the ejection fraction between 20 and 50%. Make sure that the patient doesn't have significant LV dilatation exceeding 7 centimeter, because these patients are far gone, and most likely they will not benefit. There are like few cases we have done, but the benefit of doing these cases is quite minimal. So, of course, I'm not going to go through details. Definitely the next speaker will talk about this. But the most important thing is looking at the area and looking at the mitral valve coaptation here. There are a few numbers we have to measure before we go on and decide a mitral clip. This is a paper came from Toronto in Canada. They looked at about 10 papers, and they can go down to the mitral valve area down to 3.5. This is actually our practice, but the ideal patients, they should have these numbers where the area is quite reasonable, more than 4. The mean gradient is quite reasonable, less than 5. And you can see the coaptation depth and gap. This is like a paper came from British Journal of Cardiology talking about the mitral valve area down to 3, but this is actually a small area to do. But they said if the patient is small and petite, they still accept mitral valve of 3. And this is actually not in our practice, and most of other institutes, they avoid doing these cases. And the ideal way of doing them if the mitral valve area is about 4. Of course, most of you are aware about the 2 trials between COAPT and the mitral French. COAPT is a positive study for a clip. Patients are successful in doing mitral clip in some patients, but in mitral French it's not successful, and the reason mainly because of looking at the coaptation, looking at the volume of the left ventricle. In patients with COAPT, the volume is quite smaller. It's about 101. But in mitral French, the volume of the ventricle is quite dilated. And on top of that, in a mitral French, the regurgitation volume is small. So less MR, more dilated LV, causing a failure of this study and a success of a COAPT trial. So based on that, the latest guidelines raised the intervention to the mitral valve in a primary disease or a secondary disease to level of evidence B, class 2A. That's in ACC guidelines, latest in 2020. And in European Society of Cardiology, they still think that the mitral valve in a primary disease down to 2B level of evidence B, and in a secondary MR, they made it 2A. Probably in the coming future, we will see advancement more. They can make it in 2A probably in the future. This is a paper we published last year about the complications that might happen from a mitral clip, and it is about like 4% in most of patients. And if in most of the centers, about 4% the complications might happen. That can be avoided by doing very reasonable imaging, good selection of patients. You would like to make sure that you do the proper assessment during intraoperatively to make sure that you don't have significant MR, significant MS, the mean gradient, and most of the things. Just a touch based on the tendine, just looking at the selection of patients, the ejection fraction preferable to be more than 30%, and also, again, the LV, if it is dilated more than 7, then these patients you would like to avoid, and these patients are really not doing very well after the interventions. Few measurements, I wouldn't go through them. Probably there's a lecture tomorrow about the tendine, but mainly we have to measure the anterior leaflet. We have to make sure that we have enough space in the LVOT to avoid the LVOT obstruction. There is another measurement, it's preferable, it's also done for even a conventional surgery, something called aortomitral angle, and if the angle is quite small, then the patient might have a significant LVOT obstruction. Because if you recognize here, the angle is small, that's why the valve is pointing towards the septum, and these patients are really not the preferable patient and might lead to significant problems down the road. So it's always a teamwork between interventionist and echocardiographer. You would like to make sure that they follow the same commands. It's a trust. And this is probably one of the interventionists here trying to get a goal. And I'd like just to tell you that by this slide, we are going more efficient percutaneously and less invasive. We will have a lot of interventions down the road. Mitral clip and Pascal, whenever you can see in the screen, probably is going to evolve in the coming few years, and we will have more of interventions. I hope you enjoy the rest of your stay in this beautiful town, and thank you very much.